Tá certo.
Aqui.
Tá bom.
Ahí está. Ahí. Estoy aquí.
É. Sabe quem é esse aí?
Que é este?
Não, essa é a Carolina. Daqui a pouco é o Vicente. Vicente vai dar um webinar agora.
É verdade.
Agora sim.
Now I'm sharing the screen.
Yes, we can see your screen.
I can see. Very nice.
Tu para o ano vens para o congresso, Vicente. Eu falei com ele.
Tá.
Obrigado, professor.
Wenzinho, dá o pontapé de partida.
Quê?
Acho que melhor. Fala você, Carol.
Tá bom.
Eu tô
Então,
apaisando, mochila nas costas. Eu só acompanho um pouquinho. Daqui a pouco eu desligo, tá bom?
Tá bom. Então tá na hora. Vincent, você tá pronto? Are you ready? Can we? Imad, can we start, Imad? Everything okay? Okay. So welcome everyone. It's time for us to have our last Friday of the month, and that's the day of WFNS and Rhoton Anatomy Day. It has become, for me at least, another reason to like the Fridays. I know every Friday now we have great anatomy and great neurosurgery, and I do really enjoy the last Fridays when we talk about the brain. And today we are working on the schedule, the Spanish schedule, because we have Vincent with us. And the Spanish schedule puts us into early morning in West Coast in US, midday in the East Coast, also Brazil. It's midday for me and also the guys in Argentina. It's early evening in UK, in Portugal, night already in Germany, France, Italy, Egypt, Turkey. It starts to become a little later for Imad, that's helping us with the technical part. He's in Pakistan, and also our colleagues in India. And it is really late night, almost Saturday for the guys in China, Japan, and Taiwan. Maybe some of us are still in the OR, between cases maybe, but I know that if you don't have the time to check on this talk today, there will be a repetition tomorrow. You will be receiving a note about that soon, and you can then enjoy Vincent's lecture tomorrow. So today we have Vincent, Professor Vincent Quilis Quesada, our great friend, and we are sure to be seeing great anatomy and great surgery. Welcome, Vincent. Professor Wen is also with us. He's the president of the committee, and he is in a course in Portugal, and he had taken the time to come up and to say hello. When before Vincent starts, just say hello to the people who's listening to us now.
Hello, everyone. Sorry, I'm in Portugal right now. I was in charge of a course, and here at the University of Minho in the northern part of Portugal. So welcome to our webinar, and thank you for joining us. And Vicente, thank you for being part of the team, and I wish you a wonderful talk.
Thank you, Professor. So are we ready?
Ready for you, whenever you want.
Thank you so much. So thanks for having me here today. It's an honor to be part of this World Federation of Neurosurgery Rhoton Anatomy Days, starting with brain lectures. And I would like to start giving some credit to my mentor, as always, Professor Evandro de Oliveira. He showed me the way he showed me how to understand microneurosurgery, how to study anatomy, how necessary it is to go to the lab, and how we have to apply what we learn in the lab when we go to the OR. And I would like to give also credit to my professors, Professor Wen and Carolina Martins, in my opinion, two of the best fellows of Professor Rhoton de Oliveira. I was trained by watching their lectures and reading their papers, and it's an honor today to work hand in hand with them, giving courses and lectures around the world. And today this webinar for all different students from around the world. So thank you to my mentor. In today's emotional lecture, because it is part of my PhD that I did with Professor Evandro de Oliveira. And everything started here. And this is the Sao Paulo's lab, Professor de Oliveira's lab at the Hospital Beneficencia Portuguesa. It was 2008 when I first visited Brazil and Sao Paulo. And then everything changed. It was a life-changing event at that time. And then I tried to build my lab in Valencia, and then different labs in different universities around the world. And we continue trying to spread Professor Rhoton and Professor de Oliveira philosophy around the world, giving this kind of lectures. Today, we are going to review the basal surface anatomy, so and gyre of the basal surface. But I would like to start with a short review of the lateral surface and medial surface of the brain, and finally the basal surface. And we all know that everyone have a different pattern of sulci and gyre, but we can identify a general pattern of sulci and gyre, and then different kind of variation regarding each one of us. So we have to master the main sulci, so superior frontal gyrus, inferior frontal gyrus, precentral, central, postcentral gyrus. So anteriorly we have the frontal lobe, anterior to the central sulcus. Then we have the parietal lobe divided by this intraparietal sulcus. So we have the superior parietal lobule and the inferior parietal lobule. And we can divide the inferior parietal lobule in this supramarginal gyrus around the ending point of this sylvian fissure, and the angular gyrus surrounding the most posterior part of this superior temporal sulcus. We have also an inferior temporal sulcus. So we have here the temporal lobe divided in this superior, middle, and an inferior temporal gyrus. And we start seeing how this inferior temporal gyrus is part of the lateral surface, but also part of the basal surface of the brain. We are missing here the occipital lobe. We have different kind of variation, but most of the time we have a sulcus continuing this intraparietal sulcus. We have this intra-occipital or superior occipital sulcus, and then another inferior occipital sulcus. So we most of the times have 2 or 3 sulci in this posterior part of this lateral surface. So when we study this lateral surface, we see different arteries, veins, sulci, gyre. We can easily get lost, but we have to be able to identify the main patterns of sulci and gyre to navigate during surgery. We have landmarks from the bone, and we can identify and correlate this sulci and gyre in relation to the landmarks that we have in the surface of the bone. So we can plan and perform different craniotomies, trying to expose different regions and lobes of the brain. This is a lateral view that's showing these different patterns. And here we can see a superlateral view of this lateral surface. This is postcentral sulcus, intraparietal sulcus, so superior parietal lobule, inferior parietal lobule, supramarginal gyrus, angular gyrus here, central sulcus, precentral gyrus, so frontal lobe here. The same when we start study this medial surface of the brain, we have to be able to identify the main sulci and gyre of this medial surface of the brain. So we can identify this cingulate sulcus and the marginal ramus of this cingulate sulcus and the subparietal sulcus. So we know we have externally, in this most superficial part of this surface, the superior frontal sulcus, gyrus. If deep inside, we have the cingulate gyrus, and then corpus callosum. We still have another sulcus here, the sulcus of the corpus callosum. Distally, we have the parietoccipital sulcus and calcarean fissure. So we divide this posterior part of this medial surface in this lingula, cuneus, and precuneus. Precuneus is related to the lateral surface with the superior parietal lobule. And then medially and basally, we have this mediovasal temporal region. We are going to discuss about this anatomy. And again, this part of the temporal lobe is part of the medial surface of the brain and also part of the basal surface of the brain. So we have medially and the mediovasal temporal region when we study the basal surface of the brain, and laterally part of the inferior temporal gyrus of the lateral surface of the brain. We can correlate again different parts with the different sutures and different landmarks that we have from the surface of the brain, and then the basal surface of the brain. If we pay attention in this left part of this brain, we can identify laterally the inferior temporal gyrus. This is the gyrus that is part of the lateral surface of the brain and also part of this basal surface of the brain. And we already discussed about this mediovasal temporal region. This is part of the medial surface of the brain and also the medial part of this basal surface of the temporal lobe and part of the occipital lobe. In between both, the inferior temporal gyrus and the mediovasal temporal gyrus, we have this, mediovasal temporal region, we have this fusiform gyrus. The mediovasal temporal region is divided in an anterior segment, the so-called uncus, but it is actually a little bit more extended than the uncus, then a medial segment and a posterior segment in relation to this parahippocampal gyrus. Laterally to this mediovasal temporal region, we have this collateral sulcus, and anteriorly, lateral to the uncus, we have the rhinal sulcus continuous to the collateral sulcus or not. It depends on different specimen. And lateral to the fusiform gyrus and medial to this inferior temporal gyrus, we have the occipitotemporal sulcus. So we have the main pattern of this basal surface of the brain, and of course we have the basal surface of the frontal lobe. We have this pattern of related to this age of gyrus that we have. So the orbital gyri here, we have a medial, an anterior, posterior, and lateral orbital gyri. And we have the gyrus rectus and the sulcus of the olfactory tract. We see here the olfactory tract in this parallel to this rectus gyrus, so we complete the pattern of this basal surface of the brain. We focus a little bit here to correlate this basal surface to the basal systems of the brain. We see here carotid artery here, internal carotid artery. So carotid cistern is here. Lamina terminalis cistern is just above the chiasm here. We see the anterior communicating artery complex. Chiasmatic cistern in relation to this optic nerve and chiasm. And then we have the crural system in between the brainstem and the anterior part of this mediovasal temporal region. Ambient system, just moving posteriorly in relation to this middle segment of the mediovasal temporal region, and then quadrigeminal system. crural, ambient, and quadrigeminal systems are related laterally to this mediovasal temporal region of the temporal lobe. We just dissected here the parahippocampal gyrus, and just to identify what kind of structures we have deep inside the brain. We have part of this temporal horn of the lateral ventricle. We see here anteriorly part of gray matter in relation to this most anterior part of the temporal horn. This is the amygdala of the temporal lobe. We see here part actually of the head of the hippocampus, just seeing from below. And then we can imagine the body of the hippocampus, just identifying here the dentate gyrus in relation to these deep compartments of the hippocampal formation. So just dissecting, identifying where is located the hippocampus and hippocampal formation in relation to the surface of this mediovasal temporal region and in relation to this uncus. We can see an apex of the uncus pointing medially in close relation to the third nerve and the posterior communicating artery in this carotid system. And then we have an anterior part of this uncus where we cannot see inside any structures of the ventricle or the head of the hippocampus. So we can draw a line in parallel or at the level of this apex of the uncus. We will see how the head of the hippocampus is located just posterior to this line dividing the uncus of the anterior segment of the mediovasal temporal region into anterior and posterior segments. We have to pay attention to the vessels. We have the posterior cerebral artery running from the basilar bifurcation surrounding and riding inside the crural, ambient, and quadrigeminal system, and we will have different inferior temporal branches running inside the collateral sulcus. And this is something that we will be able to identify in different radiological studies as the angiography. We will see how the arteries will run above the surface of this parahippocampal gyrus and then deep inside the collateral sulcus and then running over the surface of this fusiform gyrus. Some veins, mostly located laterally in this basal surface of the brain and draining to this tentorial surface and vein of Lavey complex in this lateral surface of the brain. Another view to identify not only the collateral sulcus here, but sometimes we have this rhinal sulcus just not continuous to this collateral sulcus and laterally to the uncus. We see here a mark of, it is not a sulcus, it is part of the indentation of the tentorial incisura. So we can imagine the relation of this anterior segment of the mediovasal temporal region in relation to the tentorial incisura and how the apex of this anterior segment it is medial to the tentorial incisura. We see here again internal carotid artery A1, contralateral A1, posterior cerebral artery, crural system, ambient system, and we see anterior choroidal artery surrounding the anterior segment of the mediovasal temporal region and then going to enter this inferior choroidal point and enter the temporal horn and the and feed the choroid plexus inside the lateral ventricles. And this is a view from below. We have to be able to identify the different landmarks and different sulci and gyri of the brain by watching the brain from different point of view. And this is like a surgical view from below for transtentorial approaches. And then we have to be able to identify the same anatomy, the same surface. Now we have here laterally the inferior temporal gyrus, occipitotemporal sulcus, fusiform gyrus here, mediovasal temporal region, uncus here, the indentation of the tentorial incisura, so the apex of the uncus, crural system here, ambient system, and then posteriorly quadrigeminal system. We have here the crus cerebri and mammillary bodies here. So this is part of this basal surface, and laterally the most anterior part of the temporal lobe and the temporal pole here and the rhinal incisura. We see here this indentation dividing the mediovasal temporal region and the temporal pole. The rhinal incisura is a good landmark during surgery. And then posteriorly, we see the rhinal sulcus. And we can continue the rhinal sulcus towards the collateral sulcus, lateral to the mediovasal temporal region. Then we can study this anatomy and retract the parahippocampal gyrus and then dissect. We focus a little bit. We see here the anterior segment of the mediovasal temporal region, the rhinal sulcus here. We see how collateral sulcus in this case is not continuous to the rhinal sulcus. Rhinal sulcus anteriorly, this is temporal pole, this is uncus. We see the rhinal incisura is a good landmark during terional approaches to identify this mediovasal temporal region, and laterally the temporal pole and planum polare. And then we can try to visualize deep inside the structures inside the ventricle and the head of the hippocampus, body of the hippocampus, and the location of the amygdala. We can try to imagine it like a hand close here, deep inside the systems, and the amygdala is like this rugby ball in location, partially inside the temporal lobe and partially deep inside the deep structures of the brain. Again, crural system is here, ambient system here, and posteriorly the quadrigeminal system. If we retract this basal surface of the brain, we can identify fimbria medially, the femorodentate sulcus, dentate gyrus, and subiculum laterally. So if we study anteriorly all this surface, we can identify intralimbic gyrus, band of Jacomanus, and uncinate gyrus in relation to the fimbria, dentate, and hippocampal formation. Then in this surface, we see optic tract. And again, we can imagine the location of the head of the hippocampus, just trying to correlate this intralimbic band of Jacomani and uncinate gyrus in this inferior surface, and the location deep inside of the amygdala in relation to this semilunar and ambient gyrus in this anterior surface of the uncus and the anterior segment of the mediovasal temporal region. And we see how optic nerve, optic tract are a good landmark to divide laterally the mediovasal temporal region and medially the basal ganglia and the brain stem. This is another specimen, just a superior view of the temporal lobe, and we remove the central core. We see here the floor of third ventricle and the hypothalamus here, brain stem, laterally, third nerve, carotid system, internal carotid artery, MCA, and one segment laterally. This is planum polare, and we can identify the anterior segment of this mediovasal temporal region, the middle segment, and posterior segment in relation to the quadrigeminal system. Then we open the ventricle to identify again the location of the head of the hippocampus. Laterally, we see the floor of the temporal horn and the collateral eminence, and posteriorly collateral trigon at the level of the atrium. We see choroid plexus attached to the choroidal fissure and inferior choroidal point, and we can follow anterior choroidal artery coming from the internal carotid artery anteriorly. Again, we can draw a line here at the level of the apex, so we can see how head of the hippocampus and partially the amygdala are located in this posterior segment, and then semi-lunar and ambient gyrus in relation to this anterior superior surface of the uncus. We follow posterior cerebral artery medially, and it is running inside crural, ambient, and quadrigeminal system. We see fourth nerve and tentorial incisura, and remember how tentorial incisura was drawing in this basal surface of the uncus an indentation that we can surgically identify. Again, we can correlate this anatomy with hand and arm, so we can imagine the head of the hippocampus and the digitation of the head of the hippocampus, and then the arm as the body of the hippocampus, and posteriorly the tail of the hippocampus. And the semilunar gyrus in relation to this rugby ball correlated to this amygdala location in this temporal amygdala that we can dissect and identify this gray matter in this temporal lobe. Lateral view of the lateral ventricle and how the choroidal fissure is surrounding the central cord. From this inferior choroidal point, we see choroidal arteries and choroid plexus attached from the foramen of Monroe and body of the lateral ventricle, atrium here, and inferior choroidal point. And again, head of the hippocampus and gray matter in relation to this amygdala. Laterally, collateral eminence as part of the floor of the temporal horn, and collateral trigon posteriorly. The systems in relation to this basal surface and mediovasal temporal region, crural system, ambient system posteriorly, quadrigeminal system, and we see here the vein of Galen, and how basal vein of Rosenthal, internal occipital vein, and internal cerebral veins will drain to the vein of Galen posteriorly to finally drain to the rectus sinus. We see lateral part of the mesencephalum, pons, and tentorial surface of the cerebellum. So we remove here the tentorium, and we are just watching at the level of the tentorial incisura. So infratentorial compartment, supratentorial compartment, and basal surface of the brain. Anterior segment, so uncus is here, apex of the uncus. We can again imagine the head of the hippocampus posteriorly, medial segment of this mediovasal temporal region, and posterior segment. We see posterior cerebral arteries and superior cerebral arteries, both coming from the basal artery, basilar bifurcation, posterior cerebral arteries segment, and how superior cerebral artery is running infratentorially to feed the tentorial surface of the cerebellum. And then posterior cerebral artery giving some different inferior branches to the inferior surface of the brain. And again, we see how the arteries are running over this surface and then deep inside the collateral sulcus, and then again over the surface of this fusiform gyrus lateral. Anterior view, so we see here part of the lateral view of the temporal lobe, part of the anterior part and the temporal pole, and the basal surface. We see medially the uncus and the apex of the uncus, posterior cerebral, posterior communicating artery, posterior cerebral artery at this at the level of the crural system, collateral sulcus here, laterally fusiform gyrus, and laterally and part of the lateral surface, the inferior temporal gyrus. And if we open the sylvian fissure, this is M1 segment, we see medially part of this anterior superior surface of the uncus, so the semilunar and ambient gyrus of this anterior segment of the mediobasal temporal region. So we can imagine the deep inside the location of the temporal amygdala inside. Laterally, we see the rhinal incisura, and we can imagine inferiorly at the level of the basal surface of the brain, the rhinal sulcus running laterally to the anterior segment of the mediobasal temporal region. Laterally, we have the temporal pole, so the planum polare deep inside the sylvian fissure. And then we cannot retract, and we can easily identify this rhinal incisura and see posteriorly the rhinal sulcus. There are very good landmarks during surgery to identify the neocortical structures laterally and the paleocortex medially in relation to the limbic system and the mediobasal temporal region. We can focus and see how anterior choroidal artery is surrounding this anterior segment. So if we follow the artery, we will completely identify the limits, the anterior, medial, and posterior limit of this anterior segment of the mediobasal temporal region. Again, posterior cerebral artery riding deep inside the crural and ambient system. So if we remove the brainstem, we totally see different segments of posterior cerebral artery and branches feeding this mediobasal temporal region. We see here subiculum and the hippocampal arteries. We will see later how it is important to identify these arteries, coagulate and cut, when we want to disconnect this mediobasal temporal region from the brain to perform amygdaloid hippocampectomies or resection of the mediobasal temporal region from anterior or from inferior approaches. We see here the uncus and again semilunar and ambient gyrus to correlate the deep structures, mostly the amygdala deep inside the brain. And superior view to see how the basal vein of Rosenthal gets different veins from the ventricle and the basal surface of the brain, and finally will drain to the vein of Galen posteriorly at the level of the quadrigeminal system. Again, anterior choroidal artery, and we see how it's coming from the distal segments of the internal carotid artery, and then we'll run surrounding this anterior segment, and then finally enter close to the inferior choroidal point and follow the anatomy of this choroid plexus and choroidal fissure. And Professor Evandro de Oliveira divided this mediobasal temporal region from a surgical point of view in 3 segments. We already discussed about the anatomy of the anterior segment. Then we have a medial segment from this inferior choroidal point from this to this line at the level of the tectum of brainstem. And finally, we have a posterior segment. Posterior segment is divided in this parahippocampal cingulate and parahippocampal lingual segments of this posterior segment of the mediobasal temporal region. We see how rhinal and collateral sulcus are the lateral limits, and as we discussed, we have a rhinal incisura as a good landmark when we enter these basal systems from a pterional approach. So when we want to access this anterior, medial, or posterior segment of the mediobasal temporal region, we have different options. We have anterior approaches, mostly the pterional approaches and variation to this anterior and middle segment. And we have lateral approaches that we are going to see transcortical and transsulcal approaches, or infralateral approaches as the subtemporal approaches. Then finally, we will get access to this posterior segment and the fusiform gyrus, performing inferior approaches and posterior approaches, the so-called transtentorial approaches to the basal surface of the temporal lobe and occipital lobe. Again, this different segment seen from above, anterior segment, so the head of the hippocampus, amygdala, in this posterior part of the posterior half of the anterior segment. Middle segment, related to the ambient system, posterior cerebral artery, basal vein of Rosenthal, subiculum, choroidal fissure, and body of the hippocampus. And then posterior segment is related to the collateral trigon, part of the body and the tail of the hippocampus, and medially related to the posterior part of the ambient system and quadrigeminal system. So we see how the parahippocampal cingulate gyrus will be riding all around the splenium of the corpus callosum. So Professor Evandro described different approaches, Transilvian approaches, or anterior approaches, or translumen insula approaches, to expose this anterior segment of this mediobasal temporal region. Pterional approach and Transilvian approaches are well known, and this is the pterional approach and the dissection of this most anterior part of the posterior ramus of the Sylvian fissure and the stem. So we see M1 segment and M2 segment around the lumen insula. We see deep inside the optic nerve, anterior cerebral artery, and carotid bifurcation, so carotid system. And we have an idea of the location of this anterior segment just in relation to the M1 segment, and laterally the temporal pole. So if we proceed deep inside, we see the lumen insula, we see part of this anterior surface of the uncus, and again, this rhinal incisura dividing medially the mediobasal temporal region, laterally the temporal pole. Deep inside the Sylvian fissure, we have the planum polare and the distal segment and branches of the MCA. So we can also identify semilunar and ambient gyrus, and we will have an idea of the location of the amygdala, the temporal amygdala, and we can imagine laterally the location of the most anterior part of the temporal horn. So we have translumen insula, or lateral approaches, or translumen insula, or Transilvian approaches, transcisternal approaches to this different lesion in relation to the anterior segment of the mediobasal temporal region. In this other specimen, we can see how different approaches can give you exposure of different parts of this anterior and medial segment of the mediobasal temporal region, but it is hard to expose the most posterior segment and the collateral trigon on the posterior part of fusiform gyrus coming from anterior in this most posterior part of the basal surface of the temporal lobe and occipital lobe. So we have described different lateral approaches, transsulcal approaches or transgyral approaches to this anterior segment of the mediobasal temporal region, but we had to damage part of the lateral surface of the temporal lobe, and there are neural structures not related to the pathology that we are going to deal with if the ABM or tumor is located in the mediobasal temporal region. And most of the time, when we perform these lateral approaches, we have also to remove the anterior part of the temporal lobe. So we actually don't think lateral approaches are the best to expose this anterior segment. We come from the idea that we have to use the anatomical pathways that we have, and try to avoid damaging the neurovascular structure not related with this the pathology. So we prefer tribunal transcisternal approaches to the anterior segment that we will show you with a surgical video. Just a review to this mediovasal temporal region. We have anterior approaches that we think are the most anatomical approaches. We have lateral approaches that can damage, as this subtemporal approach also, that can damage not only the surface of the brain, but also the Labet complex veins draining laterally. And we have also posterior approaches, interhemispheric posterior approaches. So anatomy is the pillar of our practice, and we have to master anatomy to navigate during microneurosurgery. So to expose the anterior and medial segment of the mediovasal temporal region, even to access the most posterior part, we think that the pterional transcisternal approach is the best one, and then we will use the landmarks that we have, the rhinal incisura, rhinal sulcus, collateral sulcus laterally, and medially the cisterns, and finally the choroidal fissure, to medially disconnect the anterior and middle segment, and laterally disconnect the mediovasal temporal region by opening connecting the collateral sulcus with the collateral eminence inside the temporal horn of the lateral ventricle. And this is a case of left mesial temporal lobe GBM. We see in this MRI how the tumor is located anterior and middle and posterior mediovasal temporal region. This is a regular pterional approach. This is carotid system, carotid artery. We open the sylvian fissure, the stem of the sylvian fissure. This is M1 segment. So we are now in this planum polare. We see this convexity here. We can coagulate and cut some uncal arteries coming from M1. So we have now the anterior surface of the uncus, semilunar and ambient gyrus. We see here the rhinal incisura, and we can follow deep inside and identify, we see here the rhinal sulcus. So now we have medially the uncus, anterior segment, and we can open the most anterior part of the temporal horn as we see here. So we just follow the anatomy and just follow the landmark. And now we are inside this temporal horn, and we are trying to find the inferior choroidal point that we see here, choroid plexus, inferior choroidal point. So this is the most posterior part of the anterior segment. So if we follow the collateral eminence, we open collateral sulcus. So laterally we have fusiform gyrus, anteriorly rhinal sulcus, and then medially the head of the hippocampus. And we see here this gray substance. This is the tumor, the GBM. And now we have to disconnect the anterior segment medially, and we superiorly dissect the different surface of the uncus, trying to find the apex. This is the apex of the uncus, and then we follow the anterior choroidal artery. We see here anterior choroidal artery and optic tract. And if we follow anterior choroidal artery deep inside the crural system, we will connect, as we are doing here, the systems with the ventricle. We see here even the lateral geniculate body as part of the roof of this ambient system. We see veins here in relation to the basal vein of Rosenthal. So once we disconnect laterally and medially the anterior segment, we can just connect the most medial and lateral aspects to totally remove the anterior segment of the mediovasal temporal region, part of the head of the hippocampus and part of the temporal amygdala. And now, once we remove the anterior segment, we have a nice exposure of the middle segment. So we can proceed following collateral eminence, so collateral sulcus in this basal surface, and we will open choroidal fissure from this inferior choroidal point and disconnect the middle segment. We will see here the hippocampal arteries that we have to coagulate and cut. Hippocampal arteries coming from posterior cerebral artery. We will coagulate and cut and then subpalely dissect to disconnect. We see how we are disconnecting the subiculum and parahippocampal gyrus, and we keep the pia covering the vessels of the ambient system now. Now we totally disconnect lateral and medially the middle segment of this mediovasal temporal region, so we can remove this middle segment and this part of the tumor. So once we disconnect this anterior and middle segment, we get access following the choroidal fissure to the most posterior segment of the mediovasal temporal region, and we finally connect the collateral eminence and collateral trigon, and we see here the atrium of the lateral ventricle and the most posterior part of the tumor, as we see here, this great part of the tumor, and this is the collateral trigon, so the floor of the atrium, and we are ready to finally disconnect the most posterior part of this tumor. You see how we have been following the anatomy, and this is the post-op. We see how we totally remove the tumor in this axial cut until the most posterior part and until the atrium of the lateral ventricle. Then, if we have to deal with different pathologies in relation to the most posterior part of the mediovasal temporal region or the middle segment, but not the anterior segment, or laterally located lesion in relation to the fusiform gyrus, we think the best option is to come from posterior, and mostly coming from transtentorial approaches from below, from infratentorial, and then opening the tentorium and expose the basal surface of the posterior basal surface of the temporal lobe and the most anterior part of the basal surface of the occipital lobe. We also have options to come from interhemispheric occipital approaches, but it becomes difficult to get access to this most anterior part of the middle segment of the mediovasal temporal region. Of course, we have the option of subtemporal approaches, but you see how vein of Lavey and Lavey complex veins are avoiding the retraction of the basal surface of the brain, and we will have to probably damage this lateral surface and the most lateral part of the basal surface to expose the fusiform gyrus or the deep inside located middle and posterior segment of the mediovasal temporal region. That's why we prefer to perform transtentorial approaches. This is not subtemporal, but transsulcal approaches to the temporal horn. And again, you have to damage the lateral surface of the brain and probably deal with the different patterns of venous drainage in relation to the vein of Lavey. Other options, interhemispheric occipital approaches. Posteriorly, we have less bridging veins draining the occipital lobe, but you see how we have to retract the lingula and cuneus, so the visual cortical areas, to expose the posterior and middle mediobasal temporal region. This is parahippocampal-lingual gyrus, parahippocampal cingulate. This is the splenium of corpus callosum, and we get exposure of this most anterior part by retracting and damaging the brain. So we prefer, this is how we can expose the most anterior part, but it is hard to expose the anterior part of the middle segment, and we cannot expose the anterior segment. That's why Professor Yasargil described these transtentorial approaches. He first described this approach to remove a cavernous hemangioma of the fusiform gyrus, and then he described how to come supracerebral infratentorial and then open the tent and expose the anatomically expose the fusiform gyrus and remove the cavernoma of this location without damaging the occipital lobe or exposing the lateral surface of the brain. Professor Evandro de Oliveira also published his experience with different pathology, most of them AVMs of this basal surface of the brain, as we can see here. And we perform our PhD project to describe how much exposure we can get through these transtentorial approaches. This is a surgical view from Professor Evandro de Oliveira. So we see how we bilaterally can expose the tent, and this is a supracerebral infratentorial. We have to pay attention to the bridging veins and the sinuses riding inside the tentorial layers. This is the vermis of the cerebellum and the pulmen. So we see here quadrigeminal system. And then this is a case of Professor Evandro de Oliveira. He partially removed the tent and keep the sinus intact laterally to remove an AVM of this parahippocampal and fusiform gyrus. So an AVM in relation to these branches located around the collateral sulcus and coming from the posterior cerebral artery. Sorry, and this is the view after removal of the AVM. This is an anatomical dissection. Yes, we totally remove open the posterior fossa, and we see transverse sinus bilaterally in the posterior part of the sagittal sinus. We see how we can have different patterns of bridging veins of the cerebellar hemispheres on Vermian veins draining the midline surface of the cerebellum. Once we open the cisterna magna and release some CSF, we will see how the tentorial surface of the cerebellum can be exposed, just dissecting the arachnoid, and we can expose the tentorium coming from below. We see how different can be from one side to the other. We see huge sinuses in this part, but no sinuses and no veins at this level. Usually the veins are located in the lateral half of the tens, and sometimes you have big sinuses that can make it difficult to work through the tentorium. So we have to study the patient before surgery to identify the anatomy that can make this approach possible. If we totally remove, this is a right side, this is transverse sinus. If we totally remove the tent, we see medially the mediobasal temporal region, again posterior and middle segment, laterally fusiform gyrus, and completely laterally part of the occipitotemporal sulcus and inferior temporal gyrus, where we can see how easily we can expose the fusiform gyrus and how Professor Yasargil removed the cavernoma at this level. We are here retracting the tentorial surface of the cerebellum, So we open and expose the ambient system. We see superior cerebral arteries, distal branches of posterior cerebral arteries, and then collateral sulcus. And we see how arteries enter the sulcus and then will exit the sulcus and run following the surface of the fusiform gyrus. We see here fourth nerve coming from the posterior part of the brain stem and the quadrigeminal system, and medially we see the culmen of the cerebellum. We see the quadrigeminal system medially. And this is the area of the brain that we can expose by totally removing the tens. This is the anterior limit of the tentorium. So this is the superior petrosal sinus location. This is the posterior edge of the petrous bone. And we see how the anterior segment keeps hidden anteriorly to this petrous edge, and the superior petrosal sinus that will be located in the skull base, just facing this basal surface of the brain. But we can see how the middle and posterior segments are easily exposed, and also the fusiform gyrus and posteriorly part of the occipital lobe coming from supracerebellar transtentorial approaches. This is the surgical steps in a cadaver. We usually perform a straight line in this paramedian location, but in the cadaver we perform a U-shaped incision, and we totally retracting one musculocutaneous flap the muscles from this upper part of the neck. We usually expose the transverse sinus, and we open the dura like this, just parallel to the transverse sinus, so we can get access to the quadrigeminal system and release CSF. If we cannot get access, we open a small incision here, inferior and lateral to the quadrigeminal system. Then we open the arachnoid, we release some CSF, so the cerebellum will fall down, and we then open this supracerebellar infratentorial space. We see the Vermian bridging veins medially, laterally some hemispheric bridging veins and sinuses, and this is the most common pattern of the tentorial venous drainage. We usually have this free surface in this most medial and posterior surface of the tentorium. As we get close to the transverse sinus, we will see bridging veins, but as we move deep inside, following the tentorial surface of the cerebellum, we will see how usually we get no exposure of veins, and we can expose a nice surface of the tentorium to finally resect the tent and identify the fusiform gyrus laterally and the mediobasal temporal region medially. We see here how we are working paramedially. This is midline. This is Vermian bridging veins. Culmen is located here. Ambient system and posteriorly quadrigeminal system. And we can see here fourth nerve and distal branches of superior cerebral arteries coming infratentorial. Once we remove the tent, we see the collateral sulcus, medially the mediobasal temporal region by hippocampal gyrus, distal branches of the posterior cerebral artery. Inferiorly, we see distal branches of superior cerebral artery, fourth nerve coming from quadrigeminal system from the inferior colliculi, and running anteriorly in relation to this tentorial incisura that has been removed. Collateral sulcus, so we have a nice exposure of the surface of the fusiform gyrus, and laterally even part of the occipitotemporal sulcus. We can retract and open the ambient system and part of quadrigeminal system. We see internal cerebral veins coming here, posterior cerebral artery and distal branches, and again, superior cerebral artery and fourth nerve. So we can follow ambient systems anteriorly medial to this middle segment that has been exposed of the mediobasal temporal region. And we can even get access to the petrous edge. So the superior petrosal sinus is right in here. And we have this complex of the superior petrosal veins that we usually have different veins draining to the superior petrosal sinus. And we have different kind of location, most of times at this middle point, but sometimes the vein will drain medially or other will drain laterally. So it depends on what kind of drainage. We can even coagulate and cut the sinus and get a nice exposure of the most anterior segment of the mediobasal temporal region. And we describe here in our PhD project, this is posterior root of fifth nerve. So this is Meckel's scale. See from posterior. This is internal acoustic meatus, 7 and 8 cranial nerves, ICA, looping inside internal acoustic meatus. This is the suprameatal tubercle here, and this is the petrous edge. And we see how collateral sulcus can be followed anteriorly, and we can start to identify part of the most posterior part of the anterior segment. So if we remove this suprameatal prominence, we can drill the bone. We see just above the internal acoustic meatus, we already opened the Meckel's scale. So we see posterior root, but also Gasserian ganglion here. And this is the posterior limit in relation to the lateral limit of the internal acoustic meatus. And we see collateral sulcus and rhinal sulcus. And we can even visualize the rhinal incisura. Remember, this is the landmark that we have anteriorly to divide medially the uncus and anterior segment, the entorhinal surface of the brain, and laterally the temporal pole. And we can imagine here the entorhinal area and the basal surface on the anterior segment of the temporal lobe, and medially pointing the apex of the uncus. So we totally expose this anterior segment. This is a panoramic view of the surface that we can expose using these transtentorial approaches. We see here quadrigeminal system, superior cerebral arteries, fourth nerve running bilaterally, and posterior, middle, and anterior segment of the mediobasal temporal region, and laterally all fusiform gyrus at this point. Once we remove the mediobasal temporal region, we can get access to the ventricle from below, and we see here choroid plexus and anterior choroidal artery. So this is the most inferior part of the choroidal fissure. And we see how anterior choroidal artery is coming from the system, ambient and crural system, just from anterior, from the internal carotid artery towards the temporal horn and the inferior choroidal point. And once we remove the anterior segment, we can identify the M1 segment of MCA entering the sylvian fissure. So you have to understand this anatomy from below, we have to get this three-dimensional anatomical view of the brain that we can only get from dissection of the from the lab. And that's a panoramic view as we started today. And we use these black pins to show you the area that we can expose coming from transtentorial and exposing the mediobasal temporal region and the fusiform gyrus, and how we can get access to even to this parahippocampal formation and the parahippocampal gyrus, and the hippocampus, and at the most posterior part. We can get exposure of this mediobasal temporal region and, of course, the fusiform gyrus. Again, anatomy is the key to perform and understand all these kind of approaches. And we prefer supracerebral transtentorial approaches to expose all these basal surface of the and posterior surface of the temporal and occipital lobe and posterior aspects of the mediobasal temporal region. Of course, we use this semi-sitting position for these approaches, and we usually identify midline, transverse sinus, transverse sigmoid junction, and we perform this straight paramedian incision to perform a craniotomy exposing the transverse sinus. And this is the case of a left fusiform gyrus GBM, as we see here, axial cut. This is a GBM in relation to the basal surface of the temporal and occipital lobe. We see here the tent and how the tumor is just located above the tent. So we perform this craniotomy exposing the transverse sinus. We open parallel to the transverse sinus, and then we dissect the supracerebral infratentorial compartment. We are here opening the ambient system medially and anteriorly, and then moving laterally to expose the quadrigeminal system, the most lateral aspect of the quadrigeminal system. We see here distal branches of posterior cerebral artery, distal segments of basal vein of Rosenthal, and we see the posterior aspect of the tentorial incisura and part of the parahippocampal gyrus here and mediobasal temporal region. We see how we can correlate the anatomy and how we can get a nice exposure of this tent and then remove the tentorium to expose the basal surface of the brain. We see here collateral sulcus, medially the mediobasal temporal region, and laterally we see the tumor. We see the tumor filling the fusiform gyrus. So we are going to remove this fusiform gyrus by opening collateral sulcus from posterior to anterior, and then we will find the temporal horn. So we will open the floor of the temporal horn by opening the collateral eminence, and then we will move laterally to expose the occipitotemporal sulcus and divide the basal surface laterally, protecting the inferior temporal gyrus, and medially isolating the fusiform gyrus filled by this GBM. So that's what we are going to perform. We will identify collateral sulcus and then open. Now we are opening, as we see, the collateral sulcus and then dissecting the sulcus from anterior to posterior. And of course, we have to protect these inferior branches of the posterior cerebral artery that will ride above the fusiform gyrus. We see laterally the tumor and medially the parahippocampal gyrus. Then we will move laterally and open the occipitotemporal sulcus. We are now exposing the fusiform gyrus medially, and once we isolate the gyrus medially and laterally, we can disconnect the posterior aspect of the tumor and then open the ventricle medial. We are dissecting here the tumor from the normal brain, and at some point we will open the temporal horn and the ventricle coming from below. We see how we protect this distal branches of posterior cerebral artery. We debulk the tumor, and now we see the hippocampal formation, the hippocampus medially, and laterally the tumor. We protect the arteries to totally remove the tumor, and we follow the anatomy of the basal surface of the brain. We see how we are disconnecting the tumor. And this is the anterior disconnection of this fusiform gyrus to totally resect the tumor. And finally, we will have a view of the ventricle and the atrium coming from below. So we will see the roof of the atrium. That's what we are seeing and facing now. And this is the roof of the temporal horn. So we immediately will isolate the hippocampus, and laterally we will expose, as we see here, the ventricle and choroid plexus. We see here, let me stop. So we following the collateral sulcus and try to remember how we started the surgery by a half part of tumor and a half part of healthy brain laterally. So we expose the collateral sulcus, dissect and open the temporal horn. So we have medially the body of the hippocampus and the choroid plexus here, so choroidal fissure laterally. And then we totally remove the fusiform gyrus, medially using the collateral sulcus, laterally the occipitotemporal sulcus, and then anterior and posterior disconnection. So now we are facing the roof of the temporal horn and the atrium. And we see choroid plexus, and we can imagine the location of the choroidal fissure. And this is a final view as we kept intact the arteries. And this is the result. We see how we remove the tumor and keep the medial part of of the temporal lobe and the inferior temporal gyrus. So we totally remove the fusiform gyrus and totally remove the tumor by protecting the normal brain, just using the landmarks that anatomy offers to us. Take a look here. This is the final view, laterally inferior temporal gyrus. We totally remove the fusiform gyrus, and we see here how the tent was located here. And this is the most posterior part, the so-called parahippocampal cingulate gyrus surrounding the splenium of corpus callosum. And we see how the tumor was related to these anatomical structures and how we open the atrium. And this is the choroid plexus that we were showing during the video, and how we expose the roof of the atrium of the lateral ventricle. Final result and supracerebral transtentorial approaches. I would like to finish with some words from my mentor, Professor Evandro de Oliveira. We, of course, have to master the anatomical knowledge, and that's what we learned from Professor Rhoton, and train microsurgical techniques in the lab, and then go, and that's what we learned from Professor Yasargil, if we want to achieve excellence during our daily practices. But what I learned from Professor Evandro, that we need patience and love what we do, and love the art of microneurosurgery to enjoy our job and give our patient the best result. You all are welcome to the 4th International Rhoton Society meeting that will be held in November in Taipei, Taiwan. Professor Wen is the actual president of the International Rhoton Society, and Professor Sanford is organizing this event with this nice committee of members of former Rhoton fellows and great microneurosurgeons from around the world. Thank you very much.
Thank you, Vincent. I think we had great anatomy and great surgery together. I see we are receiving some questions now. And while some more questions come, I want to just to explain that in the brain committee, we have been making some compromises in our format. We think that we have a core knowledge in brain surgery that we need to people to get reminded of. And we want to do that with time. So we want our speakers to have time enough to explain themselves, to go over the anatomy and then go over the way they do surgery using that anatomy, and also to have some discussion at the end, sometime to exchange our ideas, to exchange our experiences. Of course, we make compromises. There are several other formats to do the same, but we think that at least in the beginning, we will go on with this format, and we hope that it's been useful to all of you. I think I have maybe, I hope I'm pronouncing it right, but Dr. Dumura Alfin has a question for you, Vincent, and maybe you want to unmute, Dr. Alfin. Can I read your question? Do you mind if I read your question to everyone? If you want to unmute, go ahead and make your question. Otherwise, I will read it to everyone and also to Vincent. He's interested in the way.
Unmute.
Okay. Unmuted. So maybe should I go ahead in the sake of time? Okay. Dr. Dumura, are you willing to make it the question yourself, or do you want me to read it? It's all the way is fine. So he's interested in the way you open the tentorium, Vincent. He's interested in the incision. If you can go over the steps you make to open the tent, that is the main concern. And I would add to his question details like, do you rather have some instruments if you like angled bipolars to get that part of the tent which is behind your view? Is that any favor instrument that you have to do this step? If you can go over that again, it will be fine.
Okay. We start dissecting the tent and trying to identify the bridging veins and sinuses to be sure that there are no sinuses while opening the tent. We use straight instrument, scissors and bipolars, but we use this hook of subarachnoid scalpel that you can just catch the tentorium to bring the tentorium towards your field and then cut. We usually start cutting at the mid part, not at the level of the tentorial incisura and not laterally. Usually you have more venous sinuses. And once you open the tent, then you can follow exploring supratentorial and then avoid to damage the basal surface. And then we move usually medially to find the fourth nerve and avoid damaging the fourth nerve at the level of the ambient system. And then we also explore to identify posterior cerebral artery supratentorially, superior cerebral artery infratentorially, basal vein of Rosenthal, fourth nerve. And once we are sure that we can proceed and cut the tent, we just connect and open the tentorial incisura. And then we come from medial to laterally to totally expose the fusiform gyrus in case we have to remove a tumor at this level or a cavernoma. But laterally, as we move laterally, we are getting close to the sinuses and probably bridging veins. And then is where we stop usually if we open as much as necessary, but not all the tentorium, okay? And then we move deep inside, anteriorly. And it becomes easier to explore the basal surface of the brain until the superior petrosal sinus. This is usually the anterior limit. So a straight instrument, but a hook to catch the tentorium, and then step-by-step dissection, identifying the neurovascular structure to avoid damaging during surgery.
So we have some more, thank you, Vincent. We have some more praises for your presentation and a few more questions. I think we can get some more going on. Dr. Ayman Maidan thanks you and asks, how was face recognition post-op in that fusiform GBM patient, if you can recall?
How was, sorry?
The face recognition, the function of face recognition once you...
Was okay. I mean, the patient was almost asymptomatic before surgery and was exactly the same after surgery. It was no symptom. It was left side, but left fusiform gyrus, but no problems at all.
Dr. Andres Almendrau comments that supracerebellar transtentorial approach, in this approach, the use of the microscope is not too comfortable. I can agree with him. I'm a small person with small arms, not long arms. I do have difficulty with the approach. And the question is if you have any advices that you give to make the approach more ergonomic, or if you choose to help that with the endoscope, doing assisted microneuroanatomy, microneurosurgery, what tricks would you give in this part?
To me, it's not a big deal because I have a long arm and I feel comfortable doing this approach. But it's true that new microscopes have a big head, so they make it even more difficult if you have a short arm. So sometimes you can use old microscopes with small heads that allow you to work close to the field and use a short instrument. To be comfortable during surgery, we use some arm rests, and usually you can even use the part of the bed of the patient and then bend it in the opposite direction, so you can just rest your arms to be working secure and stable during surgery. So you have to avoid working with your hands in the air and not sit in this close to the bone and close to the field. But yeah, probably the most important thing is what kind of microscope you use. And we sometimes use the endoscope to this most anterior part of the approach. And as we get close to the petrous ridge, we sometimes use the endoscope to jump over the petrous ridge and remove this anterior segment or sac the most anterior part of the tumor. But I have to say that I feel more safe using the microscope and the microsurgical techniques, even if the approach is not comfortable. But as I told you, in my case, it's not uncomfortable because my anatomy is different.
Very prone to that. I do have some other questions. I will just pick and put two together from Dr. Kumar and Dr. Sherpa, and they are going over the same, more or less the same subject, which is position. And they're asking you combined, if you can't use in a patient the sitting position, what other position would you do the approach? And if you have tried the supracerebellar infratentorial in prone position?
Yeah, I try in prone position, but the field becomes dark and
wet,
bleeding wet, and the blood is coming towards your surgery. So in my opinion, is not comfortable and not even safe. So I prefer semi-sitting position, and if you properly use the position of the patient, there are usually no problems related to this approach, with good anesthesiologist and good monitoring of the patient. I would say and recommend to use the semi-sitting position. It's more anatomical. It is easier to dissect, as I show you. You open the sulcus, and once you open the ventricle, the gyrus will fall down. And if you are doing this surgery in prone position, the gyrus of the tumor will go far from your axis. So coming from below, once you disconnect the tumor or the gyrus or the lesion, will come close to your field. So I strongly recommend semi-sitting position and not the prone position. I don't like it. I use it several times, but not in my opinion, are not the best. Just if necessary because of the anatomy of the patient. CIA communication.
Vincent, I do have several other comments and questions, but for the sake of time, I would ask if you would receive those by email and get in touch with people who would like to discuss a little more. So I can apologize everyone for not receiving all the questions, but if you do put your emails at the chat, we will make sure that Vincent gets your questions and your comments and can reply directly to you. I would like to thank everyone, to thank Vincent for a great talk, and also Imad for helping us technically. He has been a strong rock in this whole thing. And to remind everyone that Friday is a day for anatomy, anatomical surgery. We are at the last Friday of the month, that is Brain Day. But then the month starts and we have peripheral nerves and then skull base, and eventually we will have a spine as well. So I remind everyone to save your Fridays or to work along your schedule on Friday to be able to attend all the sessions in this joint effort between the World Federation and the Rhoton Society in this in this Anatomy Day. So thank you, everyone. I think I learned a lot, Vincent. I'm sure everyone did as well. And we look forward to see everyone in the next Friday.
Thank you so much. I am honored. Thank you.
Great job. Thank you.